Josh Uzagare.
Good morning, everyone. Today I'll be presenting on a topic. My name of the presentation is the Big-Hearted History. Uh, we had Mrs. T, a 31-year-old housewife from Jharkhand, presenting to us with complaints of breathing difficulty 4 years, which has worsened over 6 months, Sana Saga for 6 months, dry cough for 3 months, and decreased urine output for 3 months. Background history: she was well until 4 years ago when she developed this breathing difficulty 2 months post delivery of a second child. There was associated orthopnea and bilateral pedal edema also along with that during that time. And she was started on medications which she was taking intermittently outside, with which the breathing difficulty would get relieved and the edema would also subside. Now she has come with the shortness of breath in the 4th month of her third pregnancy, which was worsened, started on some medications elsewhere. Uh, and it was little better, and she delivered with this breathlessness, which was not very significant 3 months ago. Now her shortness of breath has been worsening after delivery. Currently, she is NYHA 4. She also had some occasional palpitations and retrosternal pain, but it was not typical of angina. Occasional and she has no other comorbidities, or she's not taking other medications for the same. Obstetric history: she's P3L3. First child was a normal vaginal delivery 8 years ago. Girl child doing well, no complications during pregnancy. Second child was also a normal vaginal delivery 4 years ago. Child is alive and well, and she developed breathlessness during the pregnancy, but after the pregnancy, after 2 months, nothing during the pregnancy. Third child, she developed breathing difficulty during the pregnancy and the 4th month. Examination: when the patient presented to us, patient was conscious, oriented. Pulse rate was 110. It was low volume pulse. BP was 96/60. Respiratory rate was 40. She was saturating only 92% on room air. After supplemental O2, the saturation picked up. She was tachypneic and using accessory muscles. JAP was elevated. There was no pallor. There was anasaka with bilateral pitting pedal edema and abdominal wall edema. A CVS examination: the first and second heart sound were normally heard. There was a loud and palpable P2 and parasternal heave, grade 2 as well. There was no LVS3 or RVS3 when I was looked at the patient. There were bilateral basal crepitations present, and shifting dullness was also present. Other findings were within normal limits. So, with this clinical presentation, what are your differentials? She has a biventricular failure with the PAH. Which worsens, see, and it started uh, in the third pregnancy and has been worsening after the pregnancy. Okay, we are having some differentials. Any more? Okay, so the most highlighted ones are PPCM or peripartum cardiomyopathy. Sure. So that was also our first clinical differential that we considered. Other was valvular heart disease like MS, of course. Then post-viral myocarditis, nutritional deficiency. Someone said beriberi also. Selenium also can cause, or other micronutrient deficiencies, or ischemic heart disease. She had that vague retrosternal pain and palpitations, if you remember, or a hypertension-related heart disease which got exacerbated during the PIH, which was maybe not documented elsewhere. And other differentials less likely will be inflammatory disorders, but clinical features or history suggestive of the same, so that we have put it in the bottom. So we evaluated, some baseline investigations were done. She was anemic, HB was 9.4, MC was 89, counts were normal, platelets were normal, urea creat was normal. LFT showed a direct hyperbilirubinemia with mild elevation of alkaline phosphatase, and albumin was 3.1. She was not very low to explain her symptoms of anasarca, and INR was also deranged. Electrolytes were normal. ECG showed sinus tachycardia, TSH and HbA1c was normal. So we went on to further evaluate and characterize her heart failure and look for any morphological abnormalities in the heart. So this is the echo. Echo showed severe LV systolic dysfunction. EF was less than 30%. Global hypokinesia of LV. Moderate MR. AR was mild, TR was moderate, and there was PAH as well with grade 2 diastolic dysfunction, and there was some pericardial effusion also, but not causing tamponade. USG was also done, which showed post-ecotexture of liver, which could explain the LFTs, and this is the heart. So this is a large heart, and also maybe we can call it a money bag appearance, but it would have been much smaller here. So I would say it's more of a cardiomegaly component of pericardial. So the main differential for our case was peripartum cardiomyopathy. Some of the other differentials that we considered were ischemic valvular or any congenital heart disease which went missing, which was non-cyanotic, or post-viral myocarditis. Hemochromatosis, again, less likely from the blood picture. Heavy metal toxicity related like lead or cadmium can cause. Nutrient deficiencies, but she has been taking supplements, and less likely is what we thought, and we also had started anyway. Inflammatory was again considered less likely. Endocrine causes like hypothyroidism or hyperthyroidism were also considered. TSH was normal. A possible pheochromocytoma, but all the BP readings were normal, and there were no paroxysmal symptoms. And genetic, like Duchenne muscular dystrophy, myotonic dystrophy, Friedrich's, or ARVD. DMD and all will present quite early in the age. Myotonic or ARVD can present at this age. So the clinically most likely diagnosis considered was peripartum cardiomyopathy. So we'll just look a little bit more into details about that. So in 2020, ESC has given a guideline for diagnosis, and all three criteria must be fulfilled. So development of heart failure should be in the last month of pregnancy or towards the end of pregnancy or within the 5 months following the delivery. There should be absence of other identifiable causes of heart failure, and LV systolic dysfunction with should be less than 45%. There can be LV dilatation or they may not be. Usually present between 32 to 38 weeks. Sorry, there's a typing mistake here. Most of them will present after 36 weeks. Risk factors: age around 31 years and mean parity around 3, especially if age is more than 30, if you are of an African descent, multiple gestation, prior or concurrent preeclampsia or eclampsia or postpartum hypertension, maternal cocaine abuse, or long-term tocolytic therapy. And some studies have implicated selenium deficiency as well, but others have failed to show the evidence for the same. Some other factors is a angiogenic imbalance between proangiogenic and anti-angiogenic factors, and hypertensive state also contributes. Other very important mechanism that was postulated was a prolactin. So this is an abnormal fragment of prolactin that causes endothelial damage and myocardial dysfunction, and produces symptoms of cardiomyopathy. Hemodynamic stress around the pregnancy. We have all learned about the physiological modifications that happen during pregnancy and the volume shifts that are large, especially post-delivery, that happen. So that can precipitate the symptoms. There have been some genetic TTN gene truncating variant mutations also implicated. Be seen in 10 to 15% of the patients, and can be handed down to the other generation as well. Immunological, elevated TNF alpha, IL-6 and cytokines have been implicated, and maternal immune response to fetal DNA that is circulating can also precipitate. Myocarditis is another thing. So the usual history is the patient will get discharged, and after a few days the patient will come back for admission with heart failure, or it can happen at 36 weeks of gestation. Around 16% of the patients with EF of less than 35% can have a LV thrombus as well. So diagnosis is based on clinical criteria that I told, ESA 2010 guidelines. Viral infections has to be ruled out, and other etiologies like nutritional have to be ruled out, inflammatory also. Then other angiogenic factors that I mentioned earlier, the assays are still in development. We do not have those assays for development. Cardiac MRI is not indicated unless echo is suboptimal, and it does not really differentiate PPCM from other etiologies of DCMY. So if you have a DCMY, if you have a clinical picture, CMRI will not really be indicated. Coronary angiogram only if ISD is of a high suspicion, otherwise coronary angiogram is also not indicated. Biopsy also, there are no pathognomic findings, so usually is not required. So it's most likely a clinical diagnosis only. So anti-heart failure medications as usual care. And there are some other drugs also that can be added. One of them has been studied extensively is bromocriptine. It can be used as an add-on therapy to the usual care. 2.5 mg twice daily for 2 weeks, followed by 2.5 mg once daily for 6 weeks. So there are multiple articles and multiple case series and a few RCTs for bromocriptine, mostly small sample size, but there was one systemic review. I'll just talk about that. So all reproductive age group patients from all races fulfilling the ESC guidelines that I spoke earlier for PPCM were included in this, and bromocriptine and conventional heart failure therapy was the intervention, and outcomes were looked at. So after sorting out the other studies, 3 studies which were RCTs and 6 reports were included for analysis. So these are the studies, and these are the doses of bromocriptine that were used. Most of them use the same dose of bromocriptine that I had mentioned earlier, and most of them have used the standard heart failure medications that we regularly use in our patients as well. So the striking findings of that is, in patients who were on bromocriptine, they had a significant improvement in ejection fraction, LV ejection fraction, and some studies have shown mortality benefit. This study by showed clear-cut mortality benefits in patients who had the bromocriptine been used. This study also, the confidence interval is 0.25 to 1.06. If I'm being optimal and say, okay, there might be some beta error, I would say this also shows. And genetic testing recommended as 15 to 20% can be familial. Others are very important to advise contraception to the patient, especially non-estrogen containing contraception should be advised to the patient. So mortality is around 10%, and complete recovery of LV function can be seen in 20 to 70% of the patient. So clinical diagnosis, when to suspect, the differentials that we read, and bromocriptine as an add-on therapy does help. Contraception has to be advised, and prognosis, mortality is there, and around 20 to 70% patients can recover. So
Thank you. We'll keep to 10 minutes per presentation in the interest of time. And any one comment, I think we'll take one comment and then move on to the next presentation by Abhisha. Knock here. We did a case series of peripartum cardiomyopathy in our institution, and we found 1 in 10 mortality is around 10%, especially if they have severe LV dysfunction or cardiogenic shock, and percent had fetal morbidity. So that's that contraception and subsequent pregnancy. She probably had it during the second pregnancy, because the presentation in the third pregnancy is way too early to be because of peripartum cardiomyopathy. We do see early onset presentation because of ischemic heart disease in diabetics, young diabetics, poorly controlled. So when you have a very early presentation, you think of another differential rather than peripartum cardiomyopathy. Sure. Thank you, Joshua. We'll move to the next presentation. Knock.